All right, folks, we're going to get started. I know I told you between 6:45 and 7, so I'm not going to hold it against anybody if they're a little late, but they can watch the video if they need to. All right, so going over abdominal injuries, some genital injuries too. So it's not too many slides or anything. There's like 80 some odd slides. Getting towards the end of things. Y'all just make sure you hunker down and get ready to go and pay attention to what's going on as we get ready to wrap this whole entire program up. If y'all stay with me till now, I appreciate it. I'm sorry if I've been boring, and I know that there's been a lot of issues here in the past few days with myself, but I want to apologize. Listen, hang on 2 seconds, y'all. Give me 2 seconds. All right, so we're going to delve off into this. All right, we talked about this before. Trauma applies to the fundamental knowledge and provide basic emergency care and transportation based on assessment findings. We're going to go over tonight about recognizing and management of blunt versus penetrating mechanisms. Evisceration, we're going to try to dive off into that, let y'all know what an evisceration is, and then how to treat impaled objects. Well, pathophysiology assessment and management. We'll talk about the difference of some injuries between a solid and hollow organ, blunt versus penetrating mechanism, and evisceration, injuries to the external genitalia, vaginal bleeding due to trauma, and then sexual assault. All right. So the abdomen extends from the diaphragm to the pelvis. Okay. So we talked about that the other night when we know it stops at the diaphragm and it goes down and it holds all of our guts and intestines. We know that it's bulked there. All right. So the organs that make up the digestive, urinary, and genitourinary system is confined into the abdominal cavity. Significant trauma to the abdomen can occur from blunt injuries, penetrating trauma, or both. Injuries to the abdomen that go unrecognized are not repaired in surgery unrecognized and are not repaired in surgery are the leading cause of traumatic death. So if we don't know they're injured and they're just going to bleed into the abdominal cavity holds a ton of blood. If I recall, I want to say it holds almost 4 pints of blood in the abdominal cavity. So you can imagine we only have 5 pints total. So we may be in trouble there. All right, so the abdominal quadrants. Remember, we talked about this in previous chapters. The abdomen is divided into 4 quadrants. If y'all remember, you see them on your screen. There's the 4 RUQ, LUQ, LLQ, and RLQ. The quadrant location of bruising or pain can kind of tell you which organs are possibly involved into the traumatic injuries. The RLQ is the common location for swelling and inflation. So you see here, it's the lower quadrant. So you know down in here, there's the navel. Here's our pelvic area right around in here. It's going to stop here. Majority of this is where it's going to be swollen and tender on a majority of our patients that we come across. Hollow and solid organs. So the hollow organs of the abdomen include the stomach, the intestines, the uterus, and the bladder. When ruptured or lacerated, the contents will spill into the peritoneal cavity, and this will cause inflammation. And most likely going to be a severe infection. Severe abdominal pain, tenderness, and muscular spasms are all going to take place during this. Intestinal blood supply comes from the mesentery fold of the tissue that connects the small intestines to the abdominal wall. Patients with injuries here in the mesentery can bleed significantly into the peritoneal cavity. Signs of this include abdominal rigidity and pre-umbilical bruising, and they're going to guard this area. They're going to not want you to touch it because it's very tender to them. So the guarding is going to be a sign also that you have some abdominal injuries also. All right, so we show here the difference between the hollow and the solid organs. We've talked about this before. We know on this side we have the hollow, this side we have the hollow, this side we have the solid organs. So the solid organs of the abdominal include the liver, spleen, pancreas, and kidneys. These organs perform the chemical work of the body. That's a little hint, kind of tell you what's going on there. They do enzyme productions. They work about blood cleansing, the endocrine functions. We go over the energy production. Because of their rich supply, hemorrhage of solid organs can be very severe. Retroperitoneal space is in the posterior aspect of the abdomen, and it's going to be behind the peritoneum. This contains the kidneys, uterus, urinary bladder, and the majority of the pancreas. There's not a picture. I'm a picture kind of guy, so I need to add a picture into there. That would be very helpful, I'm sure. For the ones that's joining, we really haven't dived off far. I think we're on slide 12, so we're pretty good here. All right, abdominal injuries are considered either open or closed and can involve hollow and solid organs. So we showed you in the previous pictures on which where they're all located. So if you can take, right, let me just show you. Let's go back over this. So if you can take here, we're going to say that belly button's here and divide this into your quadrants. So now you can see which organs, same thing here. This is the upper left, upper right. Sorry, upper right, upper left, lower right, lower left. So now you can see and understand which organs potentially are going to affect either side. Now, these can also give referred pain. So the gallbladder has a tendency to cause a referred pain into the upper shoulder clavicle area. It mimics the chest pain. I don't know why, but it's called a referred pain, and it is more pain up into this area. I'm just going to add that in there as a little tidbit information. Figured y'all wanted some more information. All right, so some blunt injuries that can cause abdominal injuries. So we talk about the MOIs. We know that motor vehicle crashes, motorcycle crashes, falls, blast injuries, and blast injuries. Remember, blast injuries are going to have potential to rupture those internal organs too. We're going to have a pedestrian versus bicycle. Those are nasty. A rapid deceleration, a compression injury, and this all may initially appear as abrasions to the surface of the skin because we're not going to be able to put our sunglasses on and have x-ray vision to see inside the body. So we're not going to be able to see until later down the road when this patient's becoming they're being septic or they're going into shock. So we have to be careful about that and recognize those signs early. So they may initially appear to, I just said that. This may take several hours for the contusion or hematoma to become visible. I kind of talked about that too. Injuries from seatbelts and airbags. So this is kind of common because we know we all run, even if you're in the firehouse, we all run those MVCs that are just, they're all normal. Everything's fine. Why they call us out here? Well, these are the ones that I like those routine calls because you need to educate your patients too. It's your time to be able to educate them and tell them what potentially can happen. And if they do have some signs and symptoms, what they need to do. So this is your time to look like a hero and tell them. So here you can see, shows the figures of correct and incorrect placement of those seat belts on what potentially is going to hurt and where. So even here, if I get my mouse to slow, let's say this one's going to be lower if she's pregnant. So it's the seatbelt is supposed to go below the baby. And you got to think, so now you're going to potentially be compressing all of this up and the child, but that's proper placement for wearing a seatbelt for a child too, or for pregnancies. Some abdominal injuries, injuries in which a foreign object enters the abdomen and opens the peritoneal cavity to the outside. That's not normal. We're supposed to keep those and our guts inside our body. We don't want to make that an open injury. Open wounds can be very deceiving because they're going to make us think that that is a life-threatening issue, and it's very shocking to see that, but at the same time, it is not a life threat. So we're going to have a high index of suspicion just because of what we see, but the internal damage to the damage to those organs could be internal or they could be outside and they're perforated. And they potentially can become life-threatening. But if you see an evisceration, that is not necessarily a life threat or to be a life-threatening concern. But we don't need to let it go unknown. We need to make sure we see it, treat it, and work with it so we know how to move forward. So the velocity of an object can very much help you predict the amount of damage to the tissue. So as you can see on yours, so it's low velocity injuries. We know knives and other edge weapons. Even if you take and you swing an axe at somebody, that's considered a medium, small, low velocity. Some other medium velocities can be small caliber handguns and or shotguns. I don't really believe in that in a shotgun because if you're close enough, that's a high caliber. Some high velocities caused by larger weapons such as high-powered rifles and other higher-powered handguns. High and medium velocity injuries have temporary wound channels. We remember y'all remember when we talked about that, how it creates that that vortex when it goes in there and it opens everything up, and then it can potentially seal itself back, or have a sucking chest wound. Cavitation, as the pressure wave from the projectile is transferred to the tissues, so they're having internal damage at the same time from that cavitation. The higher the velocity of the projectile, the larger the cavity is produced. Some low velocity penetrations have the capability of being damaged to underlying organs. Some internal organs may not be apparent, obviously, because we can't see them, or just because of where they're injured at. At any time that a patient has an injury at or below the xiphoid process, this should be assumed that the thoracic and the peritoneal cavities have been violated. So we need to be very concerned about that because of the mechanism of injury and the underlining, the potential underlining injuries that's going to come from that is because those wounds and those small calibers, they're going to enter the body and bounce around, and they're going to cause multi-system trauma to the inside. In an evisceration, your bowels do protrude from the peritoneum. They can be extremely painful, and it can also be very visually shocking. Never, ever, ever, ever push them back into the patient's abdomen. Only perform a visual assessment, and if there's any suspicion of type of injuries, cut any type of clothing that is close to the wound away, and never pull on the clothing stuck into the wound channel. If it's in there, leave it. I ain't messing with it. And that's somebody else's job. They can take care of that. Not me. Somebody else gets paid way higher than I do to pull those out and clean them. Some hollow organs often have delayed signs and symptoms because they're a little bit bigger. Commonly spill contents into the abdomen. We do have infections that do set in, and they can take hours to days. And those hollow organs hold a little bit more fluid, so it can potentially take them a little bit longer. But when they do, they become very septic and they compensate very differently. So both blunt and penetrating trauma can cause hollow organs injuries. That's obvious, but the blunt trauma causes the organs to pop, releasing fluids in the air. Penetrating trauma causes direct injuries such as a laceration or a puncture. The gallbladder and the urinary bladder are hollow organs, and their contents will potentially be irritating and damaging if ruptured. It's just an acid that's releasing into the body. So some of those fluids move into loose spaces and voids into the peritoneal cavity, and eventually they will be found by an infection. Some free air in the peritoneal cavity produces some pain, usually indicates that a hollow organ or loop of the bowel has been perforated. If it's not rapidly identified and repaired, severe infection and septic shock will occur. Some solid organs can bleed significantly and cause rupture, rapid blood loss. It can be hard to identify from a physical exam because the patient is not experiencing significant pain at the time. Solid organs can also ooze blood into the peritoneal cavity, causing pain to slowly increase over time. The liver is the largest. The liver is the largest organ in the abdomen. Say that. That's a test question, probably. That the liver is the largest organ in the abdomen. It is very vascular, and it can contribute to hyperperfusion if injured. Often the injury can be fractured by a lower right rib, can be penetrating at the same time from the rib. A common assessment finding is referred to as pain to the right shoulder. The spleen and pancreas are also very vascular. Both of those are prone to heavy bleeding when they're fractured, lacerated, or punctured. That is referred to left shoulder pain, also occurs in some of these splenitic injuries. Excuse me while I take me a drink of Gatorade. If the diaphragm is penetrated or it is ruptured, loops of bowel may herniate into the thoracic cavity. Not good. Patients may exhibit dyspnea. Changes in position from upright to supine results in more abdominal content spilling into the thoracic cavity, and it does compress the lungs. Reason why that's important is because it prohibits the lungs from fully expanding. So them laying flat is not a good idea. The 45, and we may not have to get them set at a 90 degree, but at a 45 degree angle will be very helpful in the long run. The kidneys can also be impacted by the penetrating trauma. They can cause significant amounts of blood. Common findings is blood in the urine, which I hope nobody's had that, but blood visible or inspection of the urine means indicates significant trauma to the genitourinary system. Some of the assessments in patients will potentially be abdominal injuries, can be very challenging to interpret. Some obvious, however, some are easy to overlook. Patients may be overwhelmed with other and more painful injuries. Some abdominal injuries develop and worsen over time. Now, I'll say this, it's okay to miss an abdominal injury as long as it is not a penetrating injury. We do not have these patients long enough for them to start compensating or show signs of shock unless they've had a challenging extrication or gaining access to this patient due to terrain may be the only times that we start to see these. So if you get to the facility and you're there within a 15-minute window, and then you find out 2 days later that they had, a ruptured spleen, well, you're not gonna see that in those 15 minutes that you had that patient. So don't feel bad or be upset because you missed something. You didn't have the chance to see it. So that's why I'm saying it's okay. So the scene size up. Be sure the scene is safe. We want to make sure that it is safe for you and your partner. If you need help, y'all, I hope by now y'all know, let's call for some help. Consider early spinal precautions. Consider all of the injuries the MOI could have produced. Quickly form a general impression and note the patient's level of consciousness, because remember, we're building a rapport. We're trying to build a note of what's going on, how it's going, and let's move forward with those. Severe external hemorrhaging must be addressed before the airway and breathing concerns. Ensure that the patient has a clear and patent airway. Circulation. Treat signs and symptoms of shock very aggressively. Patients with abdominal injuries should be evaluated at the highest level of trauma. So if we suspect it at all, we're going to load and go. And it's okay to go in a hurry because our suspicion tells us that there's some underlying injuries. Okay, carry on with your business. Nobody's going to be upset with you. So we're going to use our sample and OPQ-RS2 as we're building our history. So you want to ask the patient if they're having any nausea, vomiting, or diarrhea. Ask about the appearance of any bowel movements and urinary output. Ask if they have any type of referred pain. Peritoneus can result in the pain provoked by removal of pressure. So this means a rebounding tenderness. Guarding will occur if the patient tenses up or stiffens his or her abdominal muscles. On your sample history and OPRC, again, we'll just put that. Looks like I copied and pasted my notes. Secondary assessment may have the time to perform as this detailed. Some comprehensive exams is critical in critical injury patients. It's important to do, but at the same time, we may not have enough time because of other serious injuries that we're going through there. Remove or loosen any type of clothing to the exposed injuries. If you have to, cut them off. Transport the patient in a position of comfort unless we suspect a spinal injury. Examine the entire abdomen, include all posterior, anterior, posterior, anterior, and lateral surfaces. If you have to, cut all their clothes off, but remember, you got to keep this patient's overall appearance and in general, make sure that they're safe, you know, that you're just not walking through the ER with everybody looking at them and they're naked. And you're like, well, wait, well, you need to cover them. Make sure that they're covered and that they're taken care of. Use the DCAP BTLS to help identify any signs and symptoms of injury. What's it say here? Use DCAP to look for, inspect, palpate for deformities, look for presence of contusions, abrasion, penetration. All right, so let's go back over our DCAP BTLS. Palpate for tenderness and attempt to localize. So remember, if we're palpating the abdomen, we want to start on the opposite side of the injury versus to what we have. So if we're suspecting that they're having any type of injuries, remember, if they're hurting on the left upper quadrant, we want to start on the left lower quadrant and work our ways around. Palpate the abdomen when examining the region. We just talked about that. Perform a full body scan to identify any other type of injuries. Let's see here. Inspect and palpate the kidney area for tenderness, bruising, swelling. And the only time that we want to make sure that we assess the back should be if we're log rolling them to put them on a backboard. So we want to make sure we do a full detailed assessment as we log roll them. Now we check our back. We check for any type of injuries, penetrating injuries, bleeding, anything like that in there, and check the kidneys at the same time. Once we lay them flat, it's very hard to check that area again once we're in the ambulance moving down the road. So that being said, let's try to do it one and done. Obtain our baseline vitals. That will help us build the records of what's going on. We want to make sure that we recognize that hypotension is a very late sign of shock. So be smart about when you're checking your vitals. If you notice that there's a change at all, let's be considerate of that. Let's make sure what we're doing, what we're looking, that things are being recognized. Assessment of any isolated abdominal injuries. Visually inspect the abdomen for penetrating injuries. Do not remove an impaled object. I wanted to make sure we read that on your screen too. Do not remove an impaled object. So what's it say? If an entrance wound is found, check for the corresponding exit wound. Anytime that you see an entrance wound that appears to be a bullet, always check for an exit wound. You may not have one, but I can promise you, I've been burnt one too many times that I didn't find the exit wound, and I could have made some better changes for the patient if I could have found that exit wound sooner. So always do a very thorough assessment when you're trying to locate the exit wound once you recognize an entrance wound. On your reassessment, repeat the primary assessment and vital signs, reassess the interventions and treatments that you have provided. Always communicate and document what you have found, what you see, what the scene looked like. all of that to the hospital. All right, so make sure that we pass that information on, because if not, we're neglecting that patient from the best care that they can have. So anytime we have closed injuries, we want to monitor the patient closely for evaluate for progressiveness into shock. Consider calling ALS and place them on an oral or nasal gastric tube. They suck. I'm just telling you, if you've never had a nasal gastric tube, it is the worst thing in your life. Sorry, I was trying to make sure y'all understood that. The patient may experience nausea and vomiting. They have, please, please, please have suction available. You will be thankful afterwards. Assist any type of ventilations if necessary. Always keep the patient warm. If it is 900 degrees outside and they tell you that they're cold, the patient is always right. Make sure that they stay warm. Remember, always give them oxygen. Patients with penetrating injuries generally, obvious wounds and external bleedings. However, significant external bleeding may not always be present. Maintain a very high index of suspicion when we see for serious unseen blood loss. I'm looking at your screen versus mine, and that blue period is driving me insane. Why is it not black? Always keep an eye out. Keep an eye for the abdomen that's swelling. Why is it swelling? Look for those limbs that may be swelling too from fluid. Is that just a fluid overload, or is it because of bleeding? When you're in the back of the truck with your trauma patient, there is a lot of things going on, but you have to stay on top of your game to make sure that this patient has the best treatment that we can provide. Follow some general procedures described previously for the care of a blunt abdominal injury. As well, apply dry sterile dressing to all open wounds. Inspect the patient's back and sides for an exit wound, which we talked about that. What's your say? If the penetrating object is still in place, apply a stabilizing bandage around it to control the bleeding and minimize movement. Y'all hang on one second. Let me talk to my wife. All right, thank y'all so much. All right, so here is an evisceration. This is the intestines has bopped out through this patient's stomach. You can see that it's low in the pelvic area because this is his genital area. So I'm gonna say him or her. I don't know which one it is, but this is an evisceration. That's what they look like. That is I've seen it twice, and I was like, "Whoa, my God, what's that? Why is that out?" The lady actually laughed. She didn't know either. She thought something was wrong with her, but that's what they look like. I don't know if you don't like the picture, but we're going to change it. All right, so anytime during an evisceration, we must place a sterile dressing that is moistened with saline over the wound. Apply a bandage and transport. Never, ever, 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 ever replace the protruding organ into the abdominal cavity. Keep that affected area warm. I understand we're pouring room temperature saline on that, but at the same time as once we do that bandage and we put saline all over it, we do need to cover the patient. Try our best to keep it as sterile as we can. All right, so here is steps applying an dressing for an abdominal area. So you can see here in figure A, you see it's not, the two that I've dealt with in my career didn't bleed that much at all. They actually bled from this incision area more than they did there. So we're going to cover them there. B, we're going to put the dressing on. Then we're going to make sure that it's moist. We're going to turn around and seal it. We're not pushing it in there at all. We're just trying to keep the the infections, the nasties out of the way. The genitourinary system controls reproductive functions and waste discharge. If y'all don't know that by now, we probably should not talk with me, but y'all probably should talk to somebody. So organs of the genitourinary systems are located in the abdomen. These are kidneys or solid organs. The uterus, bladder, and urethra are hollow organs. The male genitalia lie outside the pelvic cavity, except for the prostate gland, that is, the prostate gland and the seminal vessels. So on the female genitalia are contained entirely within the pelvis, except the uvula, clitoris, and labia. There's the male reproductive system. Pretty sure we should all be comfortable with that at this time in our lives. We should know how that the stork delivers the babies. Here is the female reproductive system. So kidney injuries, they're not uncommon. You can get them from obviously kidney punch. You can get them from motor vehicle collisions. I've seen them in a fall. An elderly lady slip, tripped, and fell. And when she fell, she landed on I called it like a speed bump, like the little car where the car goes up and the tires don't go over. And that's what caused her damage to her kidneys, and she urinated blood for quite a while. They are less significant injuries. They can be result as an indirect blow, such as football happens a lot, have injuries to their back, kidney injuries. A forceful blow or penetrating injury is sometimes involved also. If you suspect kidney damage, if the patient has a history or physical evidence of any of these following. So you have, let's say, abrasion, laceration, contusions on the flank, penetrating wound in the region of the lower rib cage and the above the hip, flank, or the upper abdomen. Fractures on either side of their lower rib cage or lower thoracic and upper lumbar vertebrae. And then any type of hematoma in the flank region is obvious signs of pooling, that there's some type of injury to the abdominal area. Why is there blood coming out? If we notice that there's a bad bruise, ask questions. Does this hurt? How long has it been there? So our urinary bladder injuries may result if it's ruptured. We did say a few minutes ago that urine will spill into the surrounding areas. It is very acidic. They can potentially find it at the time of surgery. If not, they will find the infection. Some blunt injuries to the lower abdomen or pelvis can cause rupture to the urinary bladder, particularly when the bladder is full and distended. Penetrating wounds of the lower mid-abdomen or the perineum can directly involve the urinary bladder. So in males, you see right there, sudden deceleration from a motor vehicle or motorcycle crash can shear the bladder from the urethra. Ooh, that sounds painful. Ooh. In later trimesters of pregnancy, bladder injuries increase from the displaced of the uterus. Where did I get that word from? Ooh, that made my own word up tonight. So you see there's a ruptured bladder right there in that picture. It can happen from the pelvic area. A lot of the injuries here, unfortunately, I'll pick on our young ladies here riding in the vehicle with their legs up on the dash. Any type that there's an accident, their legs come straight up and then can potentially cause a hip injury. And you can see some of the other injuries. They can have a pelvic rupture. So that being the case, now you can see how those happen. Rodney, I just saw your question. Chris, what times would you say would be best to use Armin? So I haven't seen an emergency blanket in quite some time. The little tinfoil blankets is what I call them, Rodney, if that's what you're referring to. I'm not going to say it's any type that, let's say if there's a wilderness injury, I can take that back. I actually have one in my hunting bag. If there's any type of injury that's out in the remote area, let's say fallen from a deer stand and they break their leg, I would probably say it's a good idea to keep them there. and put it on them. One is it helps do, one is it will recognize it and will keep them warm. If there's blood loss, they're going to get very cold. So I would say that use of emergency blanket in that point can be very proactive. It's best to use it. So, and also anytime that if I'm on the truck, I like to keep blankets on my truck. Now, sometimes the ambulances don't provide them unless it gets cold. But I'm a klepto when I go to the hospital. I kind of take a few extra sheets or a few extra blankets. I mean, how am I supposed to keep them warm if I ain't got nothing? So preventing hypothermia it's challenging in a traumatic event because we need to cover them and keep them warm, but at the same time as I gotta see, I need to be able to touch things and I can't if they're covered. So you may have to turn the heat on in the back of the ambulance. Or if you're transporting potentially in your fire engine, you're gonna have to turn on the heat. I was still showing some age here. When Katrina hit, I was still on the fire truck. I was getting ready to transfer over to the sheriff's department. And we actually transported a patient off of I-20 that was in a 18-wheeler. Like we cut him out as Katrina was coming through my area. And the ambulances wouldn't respond because the winds were too high. We transported him. It was very comfortable. Besides, it was raining. That was the best thing. Truck driver was okay. Transported to our local hospital. Ended up having my license pulled for that because we weren't able to transport in a fire truck that wasn't state approved. We hadn't declared a state emergency yet. It was crazy. So all that being said is I got my license back, but I was very scared that I wasn't. So preventing hypothermia is challenging for us. So depending on where you're at and what you do, the use of blankets or other warming devices may be best. I don't recommend applying those hand warmers or anything like that directly to the skin. Obviously, they can create burns. So external male genitalia, Rodney, I'm sorry. I hope that really kind of answered your question. If not, please let me know. Now I see the chats. I can help out a little bit better. So some external male genitourinary injuries. All right, so they are considered soft tissue wounds. I'm teaching, so I'm gonna say this. They're very, very painful and they're life-threatening to me if that happens to me. Even though it is a great concern for the patient that is injured, but they are very rarely life-threatening. This should not be given a priority over more severe wounds unless there is significant bleeding that can't be controlled. Pain is going to be referred to the lower abdomen as a referred injury. Female genitalia, the uterus, ovaries, fallopian tubes are rarely damaged because of their location. They are small, deep in the pelvis, and well protected. Sometimes during pregnancies, you'll have some damage to the uterus because it is enlarged. It does come outside of the pelvic girdle and can be injured. I would be more concerned about the child versus the uterus. So that may be more of my concern, and let the facility worry about the uterus when they have the cool tools that they can use to take care of patients. The genitalia includes the uvula, the clitoris, and the major and minor labia at the entrance of the vagina. They are very rich nerve supply, so injuries are very painful. Consider any type of sexual assault or pregnancies. Ask the patient about the last known menstrual period. Ask about sexual history. Assume all women of childbearing age are possibly pregnant. Now, I can tell you, if I have a lady that's 40, 50 years old and she's like, I haven't, unless they're actively going through menopause, had a full hysterectomy, I'll always tell them, until I can be proven otherwise, I'm sorry, I'm going to mark this box potentially pregnant, unless you're not sexually active with a male partner. I mean, I'm not trying to assume, but guys and gals, it's better to assume that we may be dealing with 2 patients versus 1 patient, and I'm okay with being proven wrong. I like for them to come back and be like, I told you I wasn't pregnant. Perfect. Thank you so much. Never, ever insert any type of instruments, gloved fingers, or any type of tampon into the vagina for controlled bleeding. Potential for patient's embarrassment. We know that. Maintain a very high level of professionalism when dealing with any type of genitalial injuries. Provide privacy during the assessment. If you are not comfortable in assessing these genitalias, I'll tell you, it's still very hard for me to be like, ma'am, I'm gonna have to look. And they're having a baby. It's still embarrassing. I've delivered, I don't know how many babies, but I'm still like, ma'am, I need to, it's more embarrassing to me than the patient's like, do you just want to look? Because at this point in their time of pregnancies, everybody in their world has been down there to see them. Unless there's an injury, remember, you may want the same person of the same sex to do that. If you have 2 males or 2 females and there's an opposite sex patient, be very cautious. It may be better to say, hey, ma'am or sir, I'm going to ask this male or female police officer, or male or female firefighter to step in the back of the truck while I examine it. We're going to make this quick as possible. I just would like somebody in here in the same sex for you to make you feel a bit more comfortable. Is that okay with you? I'm going to ask them to stay up there at your head area, but I just would like somebody to make us all feel a little bit more comfortable. It's okay to say that, maybe point the fingers on you, be like, I just want them here from me. And it just kind of helps out. There's always that third person that can help you. Okay, let's talk about this again. Scene size up. Our number one hazard should be, our number one concern should be hazards to ourselves or our patients or our partners. Look for indicators of our MOIs. Patient may avoid a decision discussing to avoid undergoing any type of physical examination. They may be embarrassed. A patient may also provide that the MOI that seems less embarrassing than the actual MOI. Quickly scan the patient to identify any life threats, which we should do this no matter what on any type of call. We should always do that. Injuries can produce a significant volume of blood. Do not avoid this area in the rapid scan. Make sure you still check their genitalias. If the bleeding is persistent, maintain privacy for the patient and inspect the exterior genitalias for visible injuries. If they have severe bleeding, just put a ABD pad, a trauma pad on the top side. Never poke anything in at all. Make sure if that's it, you'd be like, sir, you can hold this for me. Whew, thank you so much. I'm glad he did. And at the same time, he's going to be like, oh my God, he's going to want to hold it anyway. So just tell him to hold the pad on there, keep the bleeding from happening. Ensure that the patient has a clear and patent airway. If they're talking to you or they're screaming, pretty sure that their airway is patent. Just going to lay that out there. If we see any type of reasons we need to put them on a spinal mobility restriction, do it. That's okay. Not a big deal. Check their circulation. Or what, do they have a PMS ×4? Cool. Do they see any significant bleeding? Nope. Blood's going round and round and not in and out. Okay. I mean, I'm okay with that. And note the patient's level of alertness. Are they a little drowsy? Are they a little slow? I need to know what I initially see. That way that I can say, okay, well, this improved because of this, or the patient, went from this, I gave them a GCS of 14 initially, and they've dropped to a 9. Well, if you didn't have that, that's a baseline. So now we know what our baseline versus our current is. Sorry, I have the hiccups. Again, transport decision. Is it time to transport them rapidly or not? Do they need to go to a trauma center or not? We need to know those things. And when you get onto these trucks, you're going to know the status levels of your local facilities. Like your major trauma hospital, they may be on med surge diversion, or they may be on ER's full. Like a level 1 trauma center can never, ever refuse a patient. They always have to take those patients. They may tell you, be advised, you may be waiting a while, but they can never refuse a patient, just to let y'all know that. Investigate the chief complaint. I want to know what's going on. Give me some details. Let me build a picture. It may not be the best picture in the world, but let me build that picture in my head. Let me figure out what's going on. Sample, we talked about this before. Use their OPQRST to learn about the patient's pain. Ask about the patient's output for the genitourinary system. Ask about allergies to medications or environmental triggers. Repeated or previous injuries or illness can help determine the extent of the current injury or illness and address the events that led up to this. Okay, so it is 2:30 in the morning. What is different now than at 9:15 last night when you're still having this pain? Don't be rude about it. But I mean, why did you call me at 2:15 in the morning versus 9? Like, what's worse? Could you not deal with it anymore? Okay, perfect. It's what I needed to know. Pain was just too much. Cool. I can work with that. Secondary assessments. Genitourinary systems injuries can be awkward. We already talked about that. They are awkward, period. Provide ongoing life-saving treatments. And here we want to potentially have a long transport or a short transport time. When the patient has an isolated injury, you can focus on that body region that's affected. It's a little bit easier when it's just one area, or if it's a multi-system trauma, you're gonna look up and be like, oh, we 10 minutes out. I can make a hospital report. But when it's just that one localized, you're like, oh my God, are we ever gonna get there? I'll again assess DCAT BTLS and obtain the patient's vitals. I don't know why we keep saying that. I guess it's just to keep on and on, but you guys should know that no matter what, we need to assess those vitals on the regular. At this time, I'm praying that y'all have got that it has to be done on the regular. Reassessment, if you're going down the road, if it's time to reassess, let's reassess them. If you've done something, check that bandage. Make sure that abdominal injury is covered and it's sterile and it's still moist. If it's dried out, add some more. Recover it. This is the time till we start to check our interventions. Communications, documentations, always communicate everything to the hospital staff. It's okay if you give a patient report and 5 minutes before you leave, you come back, you be like, oh, hey, look, I forgot to tell y'all something. I meant to tell you this, this, and this. That's okay. Not a problem. The kidneys. So damage you may not be obvious upon inspection. You may see signs of shock or blood in the urine. Unless they pee it in a cup for you, you may not see that. You do want to treat for shock. Your best thing you can do in the field is elevate their feet. Keep their feet higher in the Trendelenburg position than their chest, and keep them warm and monitor their vitals while you're en route to the facility. If you think that their bladder may be ruptured, ask if you've seen any type of blood in their urine, or hey, when this happened, did you have the tendency to urinate and then you didn't? Signs of trauma to the lower abdomen, pelvis, or perineum. They may have real bad lower back pain. If shock-associated injuries are present, transport promptly. Get them to a facility so they can have surgery ASAP. External male genitalia. A few general rules for the treatment of injuries to the external male genitalia. Injuries are painful. I'm just gonna let y'all know they're life-threatening and painful. May not, it's really not, but make the patient as comfortable as we can. Try your best to make them as comfortable as we can. Use a sterile, use sterile moist compression to cover the area stripped of skin. If there's skin missing, do the same thing as an evisceration. You want to cover it with a sterile dressing and moist. I hate saying apply direct pressure. Be very cautious about applying pressure there. If it's already injured, we just want to be able to control the bleeding. Never ever move or manipulate foreign objects in the urethra. That is something out of our scope of practice. I've come across that. And I was like, bro, I don't know what you want me to do with that. I mean, I can take you to the hospital, and this dude was super embarrassed. So it was kind of funny. Identify and take avulsed parts to the hospital. If you see anything that's supposed to be attached and it's not, put it in a bag with the patient's name on there. If the patient has an avulsion of skin on the penis, wrap the penis in a soft, sterile dressing moistened with sterile saline. Transport promptly. Use direct pressure to control any type of bleeding, and try to save and preserve the avulsed skin. I don't know what you want me to do with it besides put it in a bag and put it on some tissue. If you have an amputation of the penis shaft, use local pressure with sterile dressing to the remaining stump. Never apply a constricting device. Don't put a tourniquet down there. It just may not fit. It just is. The stump may not be of. It's just not going to work. Wrap in a moist, sterile dressing, place it in a bag, transport in a cooled container without it directly touching ice. That's a report that I want to hear coming into the facility. I can promise you, I want to be like, ooh, I got to hear this. Hey, it happens. If there's any connective tissue surrounding the erectile tissue that's severely damaged, the shaft can be fractured or severely angled. That does happen. You can break. They call it a broken penis. It is happened, but it is only because of the shaft and they angle pretty bad. It does require surgical repair, and it is associated with intense pain, bleeding, and fear is more than anything else. I'm not real sure how you have an accidental laceration to the head of the penis, but if you do, let me tell you how to fix that. Local pressure with a sterile dressing usually stops the hemorrhage. Skin of the shaft or foreskin can get caught in the zipper of the pants. I'm just going to keep reading. If a small segment of the zipper is involved, you can try to unzip, but remember, you're potentially in swinging areas. So I'm sure he has already tried that before he called you. If a longer segment is involved, use some heavy scissors to cut the zipper out of the pants to make the patient more comfortable. The urethra injuries in males are not uncommon. Lacerations of the urethra can result from straddle injuries, pelvic fractures, penetrating wounds of the perineum. It is very important to know that if the patient can urinate and if there is blood in the urethra, that is important. Save any urination for a later examination at the hospital. That's why we have specimen cups on the trucks. If there's any type of foreign body protruding into the urethra, it will have to be surgically removed. It's not my job to do that, so somebody else can do it. An avulsion of the skin of the scrotum may damage the scrotal contents. Preserve the avulsed skin in a moist, sterile dressing for possible use in reconstruction. Wrap the scrotal content of the perineal with a sterile, moist compress and use local pressure dressing can control bleeding. Direct blows to the scrotum can result in the rupture of the testicle or significant accumulation of blood around the testes. Apply ice pack to the scrotum area and transport. I did have one of those, not personally. I took care of a patient that was an MMA fighter, and he got a direct kick, and it blew his right testes out. Also, transported early in my career, a guy that had a scrotum infection, and his testicle, well, I don't know if it was testicle or just the sac, was literally the size of a basketball. Super painful. Dude was cool, but everything we moved him, it hurt. So I can say I've dealt with those. All right, so in the female genitalia, treat lacerations, abrasions, and avulsions with most moist sterile compress. Use local pressure. Do not pack the vagina. We talked about that. Never pack it. Leave any foreign bodies in place after stabilizing with bandages. Injuries are painful, but they are not life-threatening. I'm telling you, they probably think that they are because that I don't have to deal with it. Same thing as injuries to me. They life threatening. I'm just going to tell you, to me, they are. You are going to transport with some urgency to see if they're determined by associated injuries, the amount of the hemorrhage, and the presence of shock. So if we need to transport rapidly, let's transport rapidly and get this patient taken care of. Some rectal complaint. Possible cause include sexual assault, rectal foreign bodies, hemorrhoids, colitis, and ulcers in the digestive tract. Significant rectal bleeding can occur after hemorrhoid surgery. On sexual assault and any type of rapes, they are common too. Sometimes men and children are victims, not just women. Often there is a little that you can do to beyond providing compassion and transport, but be very professional about it. If the patient has sustained multi-system trauma and you need to transport for shock, do it. Do not examine the genitalia unless obvious bleeding is required. Obvious bleeding requires application dressing, sorry. Shield the patient from curious onlookers. Document patient's history, assessment, treatment, and response to the treatment. Did what you do help them? And what did you do to help them? That needs to be documented. If it's a crime scene, go in with PD. Let PD take you. Don't destroy the crime scene. If oral penetration occurred, advise the patient do not eat, drink, brush the teeth, or use mouthwash until after physical examination. Handle the patient's clothes as little as possible. Place any article of clothing or other evidence in a paper bag, and do not use plastic because mold can grow and destroy evidence. Well, and it can also sweat if any type of clothing is hot. If it's wet, it can potentially wash it off too. So be very cautious. Always use a paper sack. Do your best there. If you can't have the same sex, be very open about what's potentially going on. If it's a sexual assault patient, sometimes it's okay to call for another transport unit. Look at that patient. If they're guarding and they're scared to speak with you, it's okay. Call for another truck to come take care of that patient. It's not crying wolf, but you're doing the best for that patient. Sometimes your service may not be able to accommodate that due to the call volume or the potential trucks that are out there, but it may be something you can call the supervisor and advise, or the ALS units that's in your area may be of the sex that you need for that patient to be transported properly. It's okay. Reach out to them. Guys and gals, that's it for tonight. I did the class code. I chose it. So I just want y'all to know that Ole Miss rocks. So there's your class code. Ladies and gents, if y'all have any questions, concerns, or problems, please let me know. I'm gonna mute it, be sitting here for a few minutes. I know a couple of y'all have emailed me or messaged me in Discord. I've not had any time to do anything. Like I said, my personal business is extremely busy. That's what I've been dealing with for the last 3 days. So I will answer you. I will do my best to do it by tomorrow to answer each one of y'all, but I can't promise that. So bear with me. I'm trying to get everything handled before I go back off to work too. All right, folks, if y'all need anything, please let me know. Like I said, I'm going to mute my mic, but there's your class code for tonight. I hope y'all have a happy Easter, safe weekend, and if y'all have any traveling, please be safe. Rodney, it's cool. I figured. So guys, y'all have a good one and happy Easter to all y'all.
Hello, Mr. Chris.
What's up, love?
Hi, this is Sydney Clark. How you doing?
I'm good. You?
I'm all right. Mr. Chris, I don't know if this is a good time to ask, but for the drill, like the boot camp that got pushed back, I was already scheduled to work because I do my work schedule in advance, and I'm having a hard time finding somebody to swap those days out with me. So, how would I go about making up that day if I can't make it?
Where you live, love?
I live in Kenner, Louisiana, like right outside New Orleans.
Tell you what, can you email me and let me get with Rob about that? Send me an email, and it's I'll get that addressed this evening. I've got to go do some work tonight till early in the wee hours of the morning, but I will get that addressed for you. Okay.
Okay.